Good evening, everybody, and welcome to this program at the Indian College of Hematology. I'll start by requesting the Dean of ICH, Dr. Tejinder Singh, to introduce us to ICH, its programs, and what the activities of ICH involve. Over to you, Dr. Tejinder Singh.
Thank you, Dr. Vikram, and good evening, everybody. I am pleased to inaugurate the first academic activity of Indian College of Hematology. Indian College of Hematology is the academic wing of Indian Society of Hematology. And today's webinar is on advances in the management of AML. And this is the first activity of the calendar year 2022. Many more are going to follow, including 2 or 3 workshops during this year. I'm happy to welcome Dr. John DiPersio from Washington University, Dr. Sylvie Freeman from Birmingham, UK, Dr. Pinkal Desai from Cornell University, and all the delegates who are participating in this program. I'm sure that all residents and postgraduates of hematology, clinical oncology, and hematopathology, they will benefit immensely from this advances in management of acute myeloid leukemia. Over to you, Dr. Vikram, for further. Thank you, everybody.
Okay. Good evening, everybody. And it's my privilege to get this program going by introducing Dr. Pinkal Desai. She's the Assistant Professor of Medicine, the Charles Lillian and Betty Neuwirth Clinical Scholar in Oncology, the Clinical Director, EIPM Molecular Aging Institute, and leukemia at the Leukemia Program in Weill Cornell University, New York, USA. Her focus of interest is on clonal hematopoiesis, and of course, she has done a lot of work in this and in myeloid malignancies. Dr. Pinkal Desai will start this program by giving us an overview of the current standard of care for young adults with acute myeloid leukemia. Dr. Desai.
Hello. Good evening. Thank you for the kind invitation. Is this okay and clear? Everything
yes,
okay to go?
Yes, clear.
Right.
Thinker.
So thank you for inviting me to give this talk, Vikram. I'm going to talk about overview of standard of care for young adults with AML. Our traditional definition of young adults is under 60 years. And we'll start with what is known to everybody as the ELN classification, and go through sort of the backbone of chemotherapy, modifications to that backbone, and sort of what post-remission therapy is considered okay based on these ELN classifications. I will not go too much into MRD data because that's going to be tackled by the subsequent speakers. Talking about genetic risk, we know that AML is divided into favorable, intermediate, and adverse. Just in short, favorable is basically core binding factor leukemias, mutated NPM without FLT3, and biallelic CBPA. Adverse is your classic, bad chromosome types, monosomies, mutated RUNX1, ASXL1, TP53, and everything else being intermediate. Now, if we look at sort of the simplistic version of induction chemotherapy, we're really talking about fit AML patients at the moment. So these are people who can undergo intensive chemotherapy, have adequate cardiac and renal function. The standard backbone of therapy that is common in the United States, and I believe in India as well, is 7 and 3, which is cytarabine and an anthracycline-based induction therapy. The anthracycline could be idarubicin, which is what we use at Cornell, 12 milligram per meter squared. The other alternative is daunorubicin, doses ranging from 60 to 90, depending on what trial you look at and age. Most of the time, the current standard is daunorubicin 90 in younger patients with AML, but you'll see that several trials where the backbone therapies and other agents were added to it actually had 60 as their backbone, because these trials started during the time 60 was sort of the standard. This chemotherapy given as for 7 days. The routine assessment for bone marrow biopsy is around day 14 to 21. Our standard is usually to do a day 14 bone marrow assessment. And the idea is to have a chemoablated bone marrow, classically defined as blast count less than 5% and cellularity less than 5%. However, there may be intermediates. There could be a little bit more cellularity, a little bit more blast count. And if that is not sort of the standard, provided it is not a completely cellular marrow where we have not achieved much cellularity reduction, as long as it's a hypocellular marrow with a little bit of excess blast, we tend to actually wait and do a repeat bone marrow biopsy again on day 21 to see what's growing back. And if it looks like the leukemia is not in remission, then you consider a reinduction at that time. If the marrow is obviously cellular on day 14, we would go for a course of reinduction, which is in general some form of 7 and 3. You could repeat the same 7 and 3. Sometimes it's 5 and 2, and in rare cases when there is absolutely no change at all in cellularity, we could even give IDAC, which is sort of like a reinduction with a different regimen. There's no standard for reinduction as such, and the chances of going into remission with the reinduction is about 30%. Once this phase is over, let's say it's ablated or given reinduction, we wait for count recovery, and once count recovery is complete, which is basically neutrophil count over 1,000 and platelet count recovering or over 100,000, a bone marrow biopsy done at that time would confirm the remission and the MRD status, which we'll talk about later in the subsequent talks. Now, once the patient is in remission, what do we do about it? It depends on whether it's favorable or intermediate or poor. If it's favorable risk, which is generally core binding factor leukemias, consolidation is in the form of high-dose cytarabine or HiDAC, which is the standard for CBF. This is defined as cumulative 18 grams per meter squared, tend to give for about 3 to 4 cycles. If it is not core binding factor leukemia, intermediate dose Ara-C, which is 12 grams per meter squared, is sort of the standard. Again, 3 to 4 cycles depending on tolerance. The one place where we do transplant favorable risk core binding factor leukemia is KIT mutated AML, core binding factor AML, which we can talk a bit later. For intermediate and poor risk ELN, the standard of care for younger patient is allogeneic SCT, and for people who cannot go through it, refuse or non-availability of donor, that would be IDAC. So this is a simplistic version of the backbone of 7 and 3. What are the modifications depending on mutation subtypes? So the few things that we tend to get at diagnosis, which is relevant in sort of triaging patients into different therapy, obviously cytogenetics, FLT3, NPM1, because those would change the standard of care, at least right now, outside of clinical trials. We're not talking about clinical trials, we're talking about standard therapy. So these are sort of the PCR-based mutation profiling that is relevant to know in upfront AML, and we tend to usually get it here in about 48 hours for these mutation types. So we look at sort of the first backbone of therapy, that is the addition of gemtuzumab ozogamicin, or GO, which is basically chelachiamycin linked to a CD33 antibody. And this was tested. It had a complicated course in United States where the trial was done in SWOG, approved, withdrawn because of excess mortality. And then this trial came up later, which is the Alpha 0701. This trial randomized patient newly diagnosed with AML to standard chemotherapy here. Daunorubicin is 60, Ara-C is 200. The GO was given in the investigational arm day 147. A second course was given if there were blast count were over 10%. Those people who achieved a CR went on to get 2 consolidations. The GO arm got 1 dose of GO on day 1 for both consolidations. If platelet recovery was delayed beyond day 45, GO was omitted. The age was 50 to 70 years. So this is not all young patients, but half of them under 60 were young. The definition in this trial of favorable genotype was having a biallelic CBPA and NPM1 without FLT3. And I make this point because some of the data are relevant. GO improved. The primary endpoint of the study was event-free survival, secondary endpoint overall survival. Both endpoints were met by the addition of GO. This is the event-free survival curves, as you see, compared to control. We're looking at better EFS. But the more sort of relevant issue about here is which subgroups do you really add GO to? So if you look at these forest plots and concentrate on the less than 60, since we're talking about young adults, there seem to be some advantage to it. The over 60 got more advantage than less than 60. Now, one of the points about this trial was that patients were allowed to go to stem cell transplant, but in reality, if you follow the way the patients fell, there were only about 14 patients out of the 200 people randomized that went on to get an SCT. So this is truly like a more not SCT population that was there. And if you look at cytogenetics, favorable or intermediate cytogenetics, there was definitely advantage to this. Unfavorable, there was not. So this is one subgroup. You would not add GO to 7 and 3 because this did not derive any benefit. If you look at the genotype of AML, non-favorable, so this is basically non-NPM1, non-double CBPA, there was advantage. Favorable, which is NPM1 without FLT3, there wasn't an advantage to this group. So again, that's one category where you might consider adding or consider other options. In US, we tend to go for clinical trials for these. Now, if you look at percentages or numbers, now the CR rates between the two arms were not different no matter what subgroup you look at, but the event-free survival was. Why would that be the case? Probably because the remission MRD was deeper, which would make sense why EFS or survival advantages were seen. But here's the 2-year event-free survival. That was the primary endpoint. For younger patients, 48 in GO versus 23%. Favorable, again, 47 versus 21. NPM1 mutated in the GO arm. Numerically, this was also significant, but NPM1 without FLT3, this was not significant. 52 versus 19, but p-value was not significant. So this was sort of the EFS. Same thing with overall survival, less than 60. There was an advantage to adding the GO arm, definitely in favorable cytogenetics, not in unfavorable cytogenetics. FLT3, yes. Favorable genotype, no. Non-favorable genotype, here it was a little bit borderline. So we've interpreted this data somewhat, some institutions add GO to intermediate risk and some don't, depending on the availability of clinical trials. So this is obviously for the standard backbone. So core binding factor, add GO. The advantage on core binding factor is actually significant, almost 20% survival. So we add GO standard to core binding factor AML and intermediate risk, that is a choice. Now, what are other subgroups and what are the standard of care in those? We know FLT3-ITD and FLT3-TKD mutations are present in about 30% of newly diagnosed leukemia. ITD, particularly the high allele ratio, is considered poor risk in the absence of NPM1. TKD mutations are not so much high risk in newly diagnosed AML, particularly in the world of FLT3 inhibition, but it is still added to the backbone. Just briefly, there's different FLT3 inhibitors. The one that's approved in the United States at this moment for upfront is midostaurin, which is a type 1 FLT3 inhibitor, less potent. There are several clinical trials ongoing in the upfront setting, randomizing to midostaurin. Two of them are crenolanib and gilteritinib, both of which are being randomized head-to-head against midostaurin. The results of that trial are currently awaited. But if you look at what led to the midostaurin approval in US, that's the RATIFY study. Young patients 18 to 60, daunorubicin 60 milligram per meter squared, plus cytarabine, plus midostaurin 50 BID given day 8 through 21. Here, bone marrow biopsies were standardly done after day 21 and not day 14 because midostaurin was still ongoing until day 21. Standard was standard. Consolidation was given again with midostaurin day 8 through 21, up to 4 cycles. Maintenance given for 12 cycles. Maintenance was allowed after SCT as well, and also for patients who did not go for SCT. This trial took almost 10 years in the making. Midostaurin improved overall survival compared to placebo, 74 versus 25 months, and this led to its approval. If you look at all of these subgroups of TKD mutations, whether you're talking about TKD, ITD low, ITD high, they behaved like they were supposed to behave. TKDs did better than ITD low, and the worst were the ITD high, but each subgroup midostaurin improved survival. So it met all of its primary and secondary endpoints, and this led to the approval. It is not approved in the United States for maintenance at this moment, but almost everybody uses FLT3 maintenance of some sort for these patients. I won't go into details of the current phase 3 trials, but there are nuances to it. Crenolanib and gilteritinib are being utilized in this setting. Now, how about the other drug that is approved in frontline setting for younger patients too? Although this trial actually happened, as you see, in 60 to 75 years, the label expanded to younger patients as well. Liposomal daunorubicin and cytarabine, or CPX-351, the phase 3 trial randomized patients to either CPX versus standard 7 and 3. FLT3 inhibition was not given on this trial. These are all high-risk secondary AMLs, therapy-related, prior history of MDS, CMML, or de novo AML with an MDS karyotype, which is our classic deletion 7s and monosomies. Induction consolidation was given in the standard fashion. CPX is given day 1, 3, and 5. Again, this was approved because of survival advantage, CPX over 7 and 3, 9 versus 5 months. CR/CRI rates were superior in the CPX arm. HSCT transplant rates were higher. Death in less than 30 and less than 60 were superior. And all of this led to its approval. In FLT3 mutations, because this is one place we don't know what to do, if you have FLT3 mutation and a secondary leukemia, do you give CPX or 7 and 3 plus midostaurin? Here, it seemed like, at least compared to 7 and 3, CPX tended to do a bit better. For the FLT3 mutation, CR rates were higher, transplants rates were higher, and survival was higher. But again, this was not compared to 7 and 3 plus midostaurin. And we tend to sort of look at what the biology of the disease might be. FLT3 ITD high, perhaps FLT3 inhibition is better, but if you have a TKD or an ITD low and a secondary AML, this is an option if it's available, Bispecifics. Again, transplant rates were higher. So one of the things that was interesting about CPX is that a landmark analysis done at the time of transplant For people who went into CR, CPX tended to have a higher survival post-transplant compared to 7 and 3. And again, it could be possible that this is because of a deeper remission or a higher MRD clearance rate, which led to better transplant outcomes. Now, I just want to quickly mention venetoclax. This is not relevant in younger patients who are fit, but if you do have somebody who is unfit, has a bad cardiac function, you can give anthracycline-based therapy. This is an option. Venetoclax is a BCL2 inhibitor. It is synergistic with HMA. The phase 3 VIAL study, which was actually a randomized trial for older patients not fit for chemotherapy, it led to survival advantage in addition to azacitidine. And that led to its approval. So this is one regimen that you could consider in younger patients if they are not fit to receive chemotherapy because of heart issues and things like that. The other biological subgroup that this may be relevant to is if you do have a younger MDS patient that transformed to leukemia and has a TP53 mutation. This is one place in the US we are digressing from our standard and perhaps treating these TP53 mutations almost like a new biological subgroup where chemotherapy tends to work less, and we tend to use venetoclax-based induction therapies, or at least there are trials ongoing to involve these patients into it. So that's one place where we may digress from sort of the backbone of intensive chemotherapy in younger patients. Now, once you do go into remission and you're considering transplant, but the transplant's not available, one option is maintenance. Again, this is a little bit of older patient type, but since it is, in theory, the trial enrolled more than 55 years patients, you have this little subgroup of younger patients that if they are ineligible for HSCT could qualify for oral azacitidine. This was maintenance therapy after completing consolidation. People who went to HSCT are not in this group, only people who could not go to HSCT. Once all of that was done, patients were randomized to oral azacitidine for 14 days out of a 28-day cycle versus placebo. And if the drug was continued until death, withdrawal, or relapse. And again, this was approved in the United States as standard because of survival advantage to oral azacitidine, 24 months versus 14.8 months median survival. The most subgroups favored maintenance, except for those people who perhaps got 3 consolidation cycles because they probably had better MRD clearance, and oral azacitidine may not be relevant in that subgroup. But everything else, the prior history of MDS, cytogenetic risks, MRD status, again, positive benefited more, MRD negative benefited less. The relevant point about this trial is that the conversion to MRD happened over time, and 37 patients on the oral azacitidine converted to an MRD negative status on trial versus 19% on placebo, so that the continued use of the drug was relevant. This was also something that worked in both FLT3 and NPM1 mutated AML. As you see over here, this is independent analysis. Not what we knew was true, NPM1 is favorable, FLT3 is not, but oral AZA significantly improved overall survival in both of these cohorts. And that the reason I brought this up a little bit was that in people who are younger, over 55, but under 60, you do have a maintenance option in FLT3 for both oral AZA and midostaurin. There is no standard as such in the United States. And we are just strictly data speaking, this has demonstrated overall survival, and FLT3 inhibition so far has not. There's obviously a lot of trials ongoing. So people use it a little bit, sometimes FLT3, sometimes oral AZA, gut feeling, biology, high FLT3, ITD may be used, FLT3 maintenance, but this is where we don't know where patients would fall. So giving sort of an overview of what younger patients with AML are being treated with, Obviously, assessment of comorbidities, performance status, prior exposure to chemo and radiation is all needed. Comprehensive profiling, we talked about that. Cytogenetics and molecular analysis is relevant. Upfront, FLT3 and NPM1 is good to know because that might change the outcome. TP53, if that's available, that could change as well. We sometimes use TP53 IHC on the bone marrow, which correlates to mutation status if we are in a sort of rush or we have a if we suspect that this patient does have a high TP53 chance, and that might turf the patient to a different sort of therapy. Patients eligible for intensive chemotherapy, good cardiac function, core binding factor AML. Standard of care is intensive chemo plus GO. GO, if you follow the alpha trial, was given 3 doses, day 1, 3, and 7. There are some other ways to sort of give it. Sometimes you give just 1 with 7 and 3 if you're not sure about tolerance, and then give 2 more in consolidation. But the standard alpha trial was intensive chemo plus GO. If you have a FLT3 mutation, intensive chemo plus FLT3 inhibitor. Non-FLT3 can give intensive chemo or intensive chemo plus GO. Therapy-related AML or with myelodysplasia-related changes, CPX351 is standard over 7 and 3. And then once this is done, a transplant, as we discussed, depending on the status, core binding factor is not transplanted except for c-KIT mutated 821 translocation. In version 16 and c-KIT, we don't transplant, but 821 with c-KIT tends to do really poorly, and we tend to transplant those patients. The rest, most of them do end up getting transplant. NPM1 without FLT3, which is theoretically favorable, is not to be transplanted, but we honestly do see higher uptake of transplant in this group because there's so many other mutations with it that there is no really true NPM1 that is by single mutation status good risk. There's always something with the GNMT3, with this, and that they end up mostly routed to transplant, at least for our institution. Maintenance, if no SCT is given, maintenance is also standard post-transplant in FLT3 mutated patients. We don't know the exact duration of a FLT3 maintenance therapy post-transplant. 2 years based on the SORMAIN study is currently standard, but there is now talk about extending it to 3 years maintenance, but it's given in some form for these FLT3 mutated patients. For the high risk of therapy-related people, when they go into transplant, there are several trials ongoing, but some kind of an HMA maintenance therapy is generally favored for these patients as well post-transplant. Patients, the rare patient which is ineligible for intensive chemotherapy, obviously, there's several, you kind of follow the older agent group, AZA and WEN, but most we're talking about less than 60. So unless you have a heart issue, you follow sort of this algorithm, but you can choose HMA and WEN, LODAC and WEN, and some other clinical trials based on availability. Again, TP53 is one subtype where HMA WEN might be favored to chemotherapy in the upfront setting. And that brings me to the end of my talk. I'm happy to take any questions.
Thank you, Dr. Pinkel. So I'll just take some questions. One is, I'll just address a few issues because we do have a fair amount of time with us. One is, if I understand right, that means 7.3 is still your standard of care induction for all patients with AML. I'm just trying to understand that there are centers that use FLAG-IDA or more intensive induction in AML. Where would you place that?
So for United States, for most patients, we are using 7 and 3 as the background. There are some centers where these FLAG-based or FLAG-IDA-based regimens are upfront. The phase 3 trials that happened in the cooperative groups in the United States failed to demonstrate a survival advantage to these high cytarabine-based induction like FLAG versus 7 and 3. So that is not considered standard for us. I know that centers like MD Anderson use that as their sort of standard, particularly in core binding factor. But because none of the cooperative groups yet have shown survival advantage to a higher intensity chemotherapy than 7 and 3, we tend to not use it. And most of the clinical trials that are happening in the United States also use the standard 7 and 3 backbone. Some data coming out of looking at FLAG iodine core binding factor leukemia looks pretty promising with GO. But again, I think that the 7 and 3 and GO also has shown survival advantage over 7 and 3. And since the backbone of 7 and 3 versus a HiDAC based regimen is not considered, it's considered equal, I think the uptake in the general United States has been lower on using these. So we tend to still favor 7 and 3.
Okay, so that brings me to the next question is, looks like the only thing that you really make a difference for is the TP53 mutations, where even in a young adult, you would go with azaven. And based on the recent literature with azaven, with many of the phase 2 studies, there's a big move in India where many patients are actually starting with azaven, and the definition of what is poor or unfit is rather loose. We do have patients presenting much later and who are a little sicker. What is your caution about, or if you have any concern about taking a young adult, with very easily to an azaven induction based on very soft criteria of being unfit? And just to give me an example of what you would consider unfit in a young adult in your practice who you may not give 7-3.
Yeah, so if you look at the ASH, so I had I was part of the ASH guidelines on considering what is fitness, and we weren't able to define what's fitness. It's so even the classic sort of FDA, US FDA criteria for unfitness is based on the Ferrara classification, which is based on organ toxicity. So you have EF creatinine clearance, that is over 3. I mean, a creatinine, serum creatinine over 3. That's, I think, in the classic form is considered unfit. So someone who comes in with obviously an EF that is low and cannot handle anthracycline is clearly unfit. So that person would get AZA and venetoclax. People who have TP53 mutations, we tend to favor azacitidine and venetoclax. There is this movement that is happening that says, could venetoclax-based therapies be used in the fit patients? And we don't have data yet to really sort of replace what is the standard backbone of 7 and 3 that has decades of data, survival advantage, post-transplant data. So it's hard to just sort of replace venetoclax. What is a push now is in very, very fit people, we're having trials that are combining chemotherapy with venetoclax. You're adding like ven to the intensive chemotherapy backbone and seeing if there is some advantage to it. My biggest concern about azaven, just using out of available data, is we do not have. So I think that the CR rates are equivalent, which is true. MRD clearance in certain subgroups are equal or better to azaven, like TP53. But we don't have standard, like, for example, somebody who's NPM1 mutated, we don't have data that the MRD clearance with 7 and 3 with azaven is as good as getting a standard induction chemotherapy. And we absolutely do not have post-transplant outcomes after azaven induction. And some of these data are being gleaned out of patients. But that's why my bias is unless out of a clinical trial, we're a bit it's a bit too soon to replace 7 and 3.
Yeah, I thank you so much. So I just want, because I'm putting out these questions because these are often things that are thrown over here, So, often the statement is that, if you get MRD negative after 2-3 cycles of when, and you take for transplant, is it different from getting MRD negative with 7-3? Clearly, we don't have the answers, and we need studies to take us through those answers. So we have a question from the chat box. One is post 3-7. This is also an area of confusion. Do you use standardly, again, sorry to put you on the spot because it's trying to get a sense of what is used in the US routinely versus what we do. Do you use intermediate dose cytosine or high dose cytosine routinely for consultation? And for most parts, all these questions are related to young adults.
Right. So our standard is intermediate dose. The only place intermediate dose being 12 gram per meter squared. High dose, which is 18 grams per meter squared, is what we define as high dose of cytarabine. The only place this is relevant is core binding factor leukemia, because these leukemias, as we know, are extremely sensitive to high dose cytarabine and have better survival with HiDAC. So HiDAC is only used in core binding factor leukemia. Otherwise, the standard is intermediate dose. And 12 is our intermediate dose, but there are clearly people who may not even handle the 12. So then you can go down to 8, 9, that kind of thing.
Sure. Thanks so much. Another question is, again, you kind of addressed it in your talk. Ashwin Nair asked, do you use oral azacitidine in your practice routinely for maintenance? And I think you addressed the question. You said midazolam is not approved for maintenance in the US. But if you were to have the option of both, which one would you choose in a FLT3 ITD positive patient?
So most of our FLT3 ITD patients are going to transplant. So the maintenance therapy, oral AZA maintenance, is something that is only relevant to people who are not transplanted. So if they're transplanted, FLT3 maintenance post-transplant is standard. Oral azacitidine is not standard or used in post-transplant maintenance setting. For people who don't go to transplant, you have an option of FLT3 maintenance or oral AZA maintenance. And usually my thought is, if you have somebody, and this oral azacitidine was just approved in the United States last year, so we're still gathering our thoughts on who should we do with this versus that. If somebody has a FLT3 ITD high allele and does not go to transplant, I would favor using a FLT3 inhibitor because their biology is very driven by a FLT3 mutation. But in theory, if somebody has a FLT3 ITD low or a TKD, oral AZA has shown survival advantage. So that's where I think there is a little bit of a thing, and there might be even approval issues to FLT3, and we would then use oral azacitidine maintenance.
Thanks so much. Archit has 3 questions. I'm going to put them all together and kind of wrap it up. So, there are a few more coming up. One, is there a role for GCSF in AML induction? Second, he asks, is there a role for granulocyte infusions in febrile neutropenia? Because we do have a lot of multi-drug resistance organisms, and we do face challenges with that. So could you take those 2 questions, please? And also he asks, what would you do if by chance you do have a patient with fungal pneumonia up front or suspect fungal pneumonia at presentation?
Okay, so for patients, so GCSF, yes, that is absolutely a role for GCSF. So we don't use it standard on everybody, but anyone who is ablated after day 14. So we're confident that we've ablated their bone marrow biopsy and they have a bacteremia. Our ASCO guidelines recommend GCSF, and we use it standardly in those patients. If someone does not have an infection, is flying through the induction, we do not use GCSF as standard. But it's important to have the day 14 ablated. So if somebody gets septic on day 9 or 10, we don't know their bone marrow status unless that person's heading to ICU and about to die, then you give GCSF no matter what, because you have to survive that episode. But for the most part, if they're on the floor with the bacteremia, you want to wait till day 14, make sure that it is empty before you give GCSF.
Thanks. Keep going. Yeah.
The other question was on
granulocytes and fungal pneumonia
infusion.
Yeah.
So we don't use granulocyte infusions as standard therapy because there's a ton of toxicity to granulocyte infusions. There's a difference between granulocyte infusions when they're given from steroid stimulated versus GCSF stimulated donors. And the trials at least were negative here in terms of getting survival advantage to granulocyte infusions. There was a recent phase 2 study of looking at progenitor cells that did show reduction in infections actually by almost 60% when it was infused prophylactically in people after completing 7 and 3. But that was a phase 2 data. It was a randomized phase 2 data. So that's different because it's more a progenitor cell. So it kind of makes mature cells as it goes versus a mature neutrophil that is being transfused, which has lots of issues with activated neutrophils causing havoc in the system, and also the problems with their duration's short, like they don't stay in circulation long enough. So that's our standard. We don't use it for anything. If somebody does have a suspected fungal infections at upfront, so if they don't have it, we use posaconazole prophylaxis standard in anybody who's going through 7 and 3 to prevent fungal infections. If they do have a fungal infection right from the beginning, then you would treat the fungal infection either with voriconazole treatment dose and kind of have to make sure the voriconazole the levels in the system are good, or the other is isobuconazole. That's the another drug we would use for treatment. We do not hold chemotherapy for these people because in the end, return of neutrophil count is what will save them. So there's no point in holding back on chemotherapy while waiting for this fungal pneumonia to get better. It's not going to get better. So you start everything together, hope for the best.
Thanks. Another quick question is, now with all these agents, IDH1, IDH2 inhibitors, midazolam, and also the decision of Azaven, you talked about IHC. In your center, for example, in Weill Cornell, what's the turnaround to get your molecular markers, and how long would you wait on a patient to start induction therapy? And would you use IDH1, IDH2 inhibitors if they're available, just to get a sense of how long you would wait for your markers before you start therapy to make the right decisions?
So at Cornell, what we tend to do, cytogenetics obviously are reported within 48 hours. The FLT3, IDH, and NPM1, we have PCRs for all three of them. So we order it routinely on everybody. So we have the status within 48 hours. So we know whether they have IDH, FLT3, or NPM1. Right now, the standard for IDH1 is we're not going for younger patients. We're not going through, we're not adding IDH inhibitor standardly. There are trials ongoing, for that, but we don't use IDH plus 7 and 3, if that's the question being asked. IDH, we just would use standard induction therapy for IDH. FLT3, obviously you need FLT3 inhibitors. The only caveat on FLT3 is that someone comes with 100,000 white cell count, we don't obviously wait. If you give Hydrea to bring the white cell count down, but if someone is really getting there where they have lung infiltration about to be intubated, you just start 7 and 3 and then add the backbone later on, because FLT3 midostaurin doesn't begin until day 8. So you can start 7 and 3 anyways to save the patient. And then if they end up being FLT3 positive, you're going to add the FLT3 in the back. If you end up being FLT3 negative, GO in theory starts day 1, but you can always skip that dose and add it at the back end. And the point of starting emergency chemotherapy is they're about to go into ICU and die. So we don't care about GO at that time. You just want to bring the white cell count down and cytoreduce as fast as you can.
Okay. So we do have 5 minutes more, so I hope you don't mind taking some more questions. We're just trying to understand. So in terms of IDH1, IDH2 inhibitors, did I get it right that you don't routinely use it?
Young patients, we do not use it. We do not combine it with 7 and 3. Okay. The older patients, it's a different story where you have a choice of doing AZA-VEN versus AZA plus IDH inhibitors. But in general, we tend to still use AZA when in that situation. If you look at venetoclax data, they tend to do good in the IDH mutated as well. But that's different.
Thank you. There's another question by Pujita asking, I'm not sure what she means. I think it's meant, she asked if there's a maintenance strategy post-transplant and co-binding factor positive leukemias. I presume those are the c-KIT positive. Is there any role for maintenance therapy in them? But you said, you already mentioned that oral AZA, there's no real data post-transplant for maintenance post-transplant.
So we do not use maintenance therapy for the core binding factors c-KIT mutated that go into transplant. So it's just standard HSCT surveillance, but no maintenance.
Sure. So Kannan asks, in an AML, elderly AML FLT3 ITD positive, will you use add midostaurin to ven AZA upfront, even though he knows the data is not available? He says that specifically as well.
So AZA ven data for FLT3, the status is they do go into remission, but they don't retain remission. So there's the duration of remission is slower in FLT3 patients. There are phase 2 data available for the triplet of AZA, ven plus gilteritinib that showed about a 90% CR rate, and at least in the short follow-up, seemed like it was doing okay. So if we don't have a clinical trial, we actually do tend to use off-label triplet.
You do? That's good to know. Okay. So it's a confession, I guess. Okay. So just one or two quick questions. Akansha Garg asked, role, I mean, it's an older concept, but is it still viable, adding dasatinib with 7-3 in co-binding factor leukemias?
Yeah, no, I think that has fell out of favor, particularly with the addition of the gemtuzumab with the 7 and 3, which has shown to have survival advantage in core binding factor leukemia. Dasatinib has fell out of favor, and we just use GEO.
Okay, so one or two last questions before we close. We just about got a minute. Nidhi Jain asks, in which NPM1 muted AML without FLT3 would you consider HSCT and CR1?
So that is the category which I was talking about, that there is it's very difficult to really define what is favorable NPM1, because we know that NPM1 definitely NPM1 with DNMT3A mutation, we transplant. Those outcomes have been poor in NPM1 mutation. We never see a really classic NPM1 mutation that is by itself. So the subsets of IDH with NPM1, NPM1 with DNMT3A, we tend to actually transplant, particularly IDH2 plus NPM1 and DNMT3A plus NPM1. The other NPM1, it depends on whether you have the ability to monitor your PCR. So we are heavily looking at NPM1 PCR-based MRD monitoring, because that's supposed to guide us to help us whether this patient's going to do well, and if they achieve an MRD negativity, we tend to monitor with PCR. If you don't have a PCR monitoring-based strategy, it's a little tough to truly say that you're doing a good job, and I would favor transplant in that situation.
Okay, two quick questions, Pinkal. Sorry, and we have to really wind up here because we're running out of time. So, very short answer to role of day 14 bone marrow. Can you do without it? And Shyam Rati is asking, what is your view on FLAG-IDA with ven for refractory AML? Would you reduce the dose of cytosine or keep the standard dose of cytosine with FLAG-IDA with ven in refractory AML?
So taking the first question, so day 14, there's no real reason not to do a day 14 bone marrow biopsy. The only person we don't do it on is if they're so sick and septic that there's no way they can handle a reinduction, then we don't do it. Let the patient just recover. But if persons can handle a reinduction, you really do want to know what's happening to their day 14 marrow and maybe do the reinduction a bit sooner rather than wasting time waiting for the disease to come back on day 28. And you can also give GCSF to aid count recovery if you know that someone's ablated. But if someone cannot handle a reinduction because they've reached their anthracycline max, or they're just too sick, then there's no point in doing day 14. So that's a place we won't do it. For FLAG-IDA-Wen, you have to reduce cytarabine from the standard, because when the trials were done in the relapse setting using standard cytarabine, these people all ended up in the ICU and super sick. So you have to cut down on the dose of cytarabine for FLAG-IDA-Wen.
Thank you so much, Pinkal. That was really illuminating. Thank you so much for your time and coming on for this talk. We really appreciate it. Hope to have you more often over here. And with that, I'll move. Thank you. Bye. There's questions coming up, but I guess we will see if we can send you an email, and we'll send the email to all the people over here if they want to continue to communicate with you. With that, we'll move to our second talk. It's our privilege and honor to have with us Dr. Sylvie Freeman. She's the professor of hematology, honorary consultant at the Institute of Hematology and Immunotherapy, University of Birmingham, Center for Clinical Hematology, Queen Elizabeth Hospital, Birmingham, UK. She's done most of and runs the central laboratory for immunophenotyping in AML. So all the UK AML trials you see, a lot of the central laboratory work comes from Sylvie Freeman's group. And she's also a member of the ELN International Group for MRD in AML. That's another area, a lot of confusion in India about to use MRD, not to use MRD, which is the best way to go. There's also a lot of confusion with all these molecular tools out there. How do we use it? How do we go forward? To address all this, we have with us Dr. Sylvie Freeman. Over to you, Dr. Sylvie Freeman. Thank you so much for your time.
First of all, it's a great pleasure to be with you all and to participate in this. Let me just share my screen, and hopefully you can see that.
Yes, we can. Perfect.
Excellent. Okay, so first of all, I think we use molecular diagnostics and risk stratification in AML to make sense of AML heterogeneity, and by doing so, we want to match up patients with the treatment that's best fitted for them. But although genetics have been used for risk stratification, nowadays we also use it to allocate induction. So, for example, gemtuzumab, mainly for core binding factor AML patients, midostaurin upfront for induction for FLT3 mutated patients, and CPX for AML with myelodysplasia related to changes. And then from the first course of treatment, we can then also input information from the patient's response to therapy to assess their future relapse risk. And that, as you know, measurable residual disease assay provide a more sensitive and specific measure of response than has been allowed up to now by morphology. So talking first about genetic risk classification, most people will be, of course, familiar with the ELN risk classification, which integrated specific molecular results, including NPM1 mutations and FLT3 mutations, to the very well-established cytogenetic risk classification first brought out by David Grimwade. Now, this risk classification is highly prognostic for standard chemotherapy. And I'm not going to go through the different genetic abnormalities listed here, as most of them will be very familiar to you. But I do want to highlight one test that is required to allocate patients between the different subgroups, the FLT3 ITD allelic ratio. And there has been variability in the results of this test between laboratories. As you know, it's not simply equal to variant allele frequency. And certainly as the technology develops, so for the moment, most labs report it from capillary electrophoresis, but increasingly next generation sequencing methods are going to be used. So, there will be a requirement for further standardization of this test. Of course, an AML cell may not just have one single genetic abnormality. Quite often there'll be combined mutations within clones and subclones. And this will mean that there are different relapse risks associated with these different combinations. But making sense of the prognostic implications of these combinations and mutations requires larger and larger patient data sets, particularly for rarer mutations. And we've been talking about, all the confusion with this, and there's been quite a few publications coming out And I've listed some of the, what I regard as some of the key publications on this slide, which may appear a little bit busy because the field is very busy. And all these data will probably input to how we improve our genetic risk classification. And this will be including not just single or combined molecular predictors, but subclonal heterogeneity. So the first one's been mentioned about in the previous talk, and that is triple hit AML, which is the FLT3-ITD, NPM1, and DNMT3 mutations, and these may be associated with a particularly adverse outcome. Secondary risk AML mutations, subtypes will define a molecular subgroup, and that was presented at EHA last year from a cohort of 2,000 patients. The French have shown that for the older patients, those with greater than 60, relatively few genetic abnormalities can be grouped together to very well stratify patients' outcome after standard chemotherapy, as you can see from the outcome curves on the right. And then there's been some very large studies looking at what's called clonal architecture, which basically means it's a relatively relative variant allele frequencies and mutations in combinations by American and by the German groups, and the latter using machine learning. And from the German data, it talks about IDH2 mutations. It looks as though one mutation, the R140, actually has a better prognosis than the R172. So I'm now going to turn to the how MRD can be used, on top of all this information to help inform treatment decisions. I think the first way that MRD can be used is by MRD persistence during or after treatment. That will identify patients who have a suboptimal response to treatment. The next way in which it can be used is before a potential allogeneic transplant to give an idea of the leukemia load before that transplant and inform transplant decisions. And then the third is to define MRD relapse by continued monitoring of patients, after treatment, off treatment, and that can include after transplant. And the rationale for this is to enable early intervention and hopefully improve the patient's outcome. And as you can see from the graph below, different MRD assays have different sensitivities, but it's very important to say that even the most sensitive MRD assay, the qPCR assay, MRD negativity does not mean eradication of leukemia. So we have a very strong evidence base for MRD as an independent prognostic factor. And this evidence base is shown on this slide, and data contributed by different assays and at different time points during the standard treatment pathway. And this evidence base has been brought together by recent meta-analyses. And the most recent showed that the benefit from being MRD negative at any point after chemotherapy translated into a hazard ratio of 0.36 for overall survival. Now, although the data contributed to this evidence base has been from different types of MRD assays, I will point out that flow MRD contributed the majority of that data, and then it was qPCR. And that's not really surprising, since these two assays have been most in use in clinical labs and most validated. So the prognostic advantage of MRD negativity is apparent right after the first course of treatment. And in our NCRI ML17 trial, over a very large number of younger adults, patients who are negative by flow MRD had an 5-year overall survival of 70%. They weren't classified as poor risk. And that was compared to MRD positivity, which gave a similar outcome to patients who were refractory, classified as partial remission. And the prognostic benefit from being MRD negative was also apparent even if patients are refractory by morphology. And that's been shown by us and other groups as well. So we have an evidence base for MRD, and we also have guidance on MRD implementation. And the first consensus recommendations were issued by the ELN in 2018, and these have been updated at the end of last year. And these guidelines are there to help the community for technical and both clinical implementation difficulties. So looking at the MRD assays that we've got in our toolbox, the first one is real-time quantitative reverse transcriptase PCR, and this uses RNA, and it is suitable for AMLs with genetic fusions and with large insertions, mutations, as in NPM1 mutated AML. And the results you get back from it is basically a ratio, sometimes expressed as a percentage, and that ratios of target copies over the housekeeper gene, which is now sort of able. Flow cytometry, you require fresh leukocytes for that, and that's, as you all know, you can apply it to most AMLs, and the result is expressed as a percentage of leukocytes. Now, still requiring further validation for more widespread use are the next generation sequencing-based assays, including those which are being developed for FLT3-ITD mutations. Again, these could potentially be applied to most AMLs, and the format of the result is a percentage variant allele frequency. And I'd just like to point out that a 0.1% variant allele frequency is equivalent to 0.2% or more cells of leukocytes. And then finally, we have digital PCR, most commonly droplet digital PCR, and that's been used mainly for IDH mutations and FLT3-TKD mutations. And one of the issues with this is you do need to develop patient unique assays, so they're not so suitable for high throughput. Now, interpretation of MRD assays can cause some confusion. What do we mean by MRD negative? An MRD negative can mean that you get a result which is below the assay detection limit, or it means it's below the threshold linked to clinical risk. And the detection limit of an assay will depend on several factors: sample quality, which is really important, assay confounders, and what I would call and others call background. What do we mean by background? And the answer to that is the MRD signal from leukemia initiating cells? If it's not, that's background. But background can be divided into two things. You can talk about technical background and biological background. All assays have technical background with all the different problems that come from doing things in the laboratory. But the biological background will depend on the platform used. For example, for qPCR, you may detect your signal, your fusion signal, but that signal may come from differentiated cells which don't have leukemia initiating potential. Flow cytometry, there may be an aberrant in the phenotype, which actually reflects a dysplastic or stressed hematopoietic cell rather than leukemic initiating cells. And NGS mutation panels, the biological background may be from clonal hematopoietic mutations. So to interpret the MRD assays, the next question is, which level means that we should consider further or different treatment in the context of the information from the genetics and the other patient risk factors. And the recommendations that have been put forward in the ELN have had to take into account the current limitations of background validated assays and the current clinical evidence from trials, for example, after induction chemotherapy. So for flow cytometry, the most validated threshold is 0.1% in younger adults across trials. And in PCR, it's 3 to 4 log reductions or less than 2%, which is equivalent to 2,000 transcripts per 10,000 able copies in the bone marrow. So these thresholds are what are recommended, but there should be caution with decentralized testing if you get methodological analytical variation, as this can reduce prognostic value. And there's also got to be caution when using MRD results when there's no published data for treatment guided decisions. So we use MRD a lot in the UK, but we know that some decisions are made on a patient-to-patient basis rather than depending on a published cohort. The ELN MRD assessment algorithm for different AML subtypes is summarized on this slide here. I will go into the detail of the different subtypes, but the point I want to make here straight away is that except for qPCR, bone marrow is recommended as the tissue, and that is because peripheral blood may have a high predictive value if MRD positive, but when MRD negative has a less certain negative predictive value. And that's also applies to the poor quality bone marrow, hemodilute bone marrow. So let's go on to specific AML subtypes. So first of all, the core binding factor AMLs. I'm just going to bring out some of the points that the updated recommendations are now making. So for core binding factor AMLs, MRD by qPCR, which amplifies the RNA transcripts once it's been reverse transcripted into cDNA. So after 2 cycles, positivity in the blood is prognostic, but in fact, about 50% of patients won't relapse because they'll be chemosensitive to further treatment. And therefore, it's not recommended the MRD result after 2 cycles should initiate treatment change. After consolidation, should recommend treatment change if there's less than a 3 to 4 log reduction. And that's based from several studies, including the MRC study and German study. And that is because there is a significant impact on survival from being MRD positive after consolidation. The other recommendation we have is that for 2 years, at least, unless obviously somebody relapses, in which case it could be longer, that there should be sequential monitoring for core binding factor AMLs, 4 to 6 weekly peripheral blood, or 2 to 3 monthly bone marrow. Now, you may remember that previously it was recommended every 3 months, but a recent study has shown that even if you have very good adherence to 3 monthly bone marrow monitoring, 74% of the relapses may actually occur within those 3 months, and therefore 2 monthly is needed, and the equivalent for that is to 4 to 6 weekly peripheral blood. However, most of the relapses in core binding factor AML will occur in the first 9 months. So moving on to NPM1 mutated AML, and there was a question, this again, the test that's recommended for this is PCR, quantitative PCR, and after 2 cycles, there are 2 studies which show that this was highly prognostic if MRD positive in the peripheral blood, the study from our group and the study from the French group. So in the UK, we will use this for risk stratified patients after course 2. Elsewhere, even if that's not used, then after consolidation, if there's MRD positivity in the bone marrow, should consider treatment change. But you will notice that in the green box, the definition of MRD positivity has been changed slightly to 2% or more of the target versus the control genes. And I'll explain that in the next slide. Sequentially, for 24 months, again, like the core binding factor, and again, we recommend 4 to 6 weekly in the peripheral blood. Then we don't recommend if there's a change in treatment, there's stable or low-level PCR MRD. Now, let me explain this a little bit further. So in NPM1 mutated AML, what does PCR MRD positivity at the end of treatment mean? We've all experienced in core binding factor AML the low positive results, and a stable low positive result has not been recommended for a change of treatment. But there's now data for NPM1 that if you look at patients who have less than 2% MRD at the end of treatment, by the sediment plot you can see below, actually 50% of those don't progress without any further treatment. There's a higher risk that these low-level molecular MRDs will progress if they're FLT3 IgD positive or have less than a 4-level reduction. But in the other patients, low-level MRD positivity doesn't initiate relapse, and that may be me because, like I said before, this is biological background. So the positivity is from differentiated cells, or possibly, it's the immune system in action. So I'm next going to discuss a case of a patient who doesn't fall into either of these two categories. And she was a 53-year-old lady with de novo AML who had no dysplasia by morphology. She had a normal karyotype. And the NGS panel showed that she only had an R172 IDH2 mutation. So she is classified as ELN intermediate risk. We potentially know now that the R172 mutation carries a higher risk of relapse. She received standard chemotherapy and was in complete remission after her first course. And there was a request for flow cytometric MRD monitoring from the post-course too, but the diagnostic sample had not been received. So by the ELN recommendations, this lady comes under the other AML subtypes, MRD monitoring. And the ELN recommendations say that outside mutant NPM1 core binding factor, or APL, basically all the AMLs can be monitored by PCR. Patients should be monitored for MRD using flow. And I'll provide some of the rationale for that in a bit. The NGS MRD monitoring in these recommendations is stated as useful to refine prognosis in addition to flow cytometry. But to date, we don't have enough evidence to recommend NGS MRD as a standalone technique. So it was totally appropriate for this lady to be monitored by flow. And for frontline chemotherapy, if a patient has MRD of at least 0.1% in their bone marrow, treatment should be considered to reduce relapse risk. Now, this lady didn't have a diagnostic sample. And you'll know your MRD terminology. So a leukemic aberrant immunophenotype means the abnormal immunophenotype, usually of the diagnostic leukemia, sometimes of the relapse leukemia. And the most sensitive and specific leukemic aberrant immunophenotypes for tracking MRD among normal regenerating bone marrows have to be in the immunophenotypic empty spaces of normal blasts. Now, the different from normal analysis also relies on those empty spaces and is defined by a set panel. So you can do MRD, flow MRD monitoring without knowing the diagnostic labe. But at diagnosis, 1 in 10 patients don't have an aberrant immunophenotype. So if you don't have your diagnostic immunophenotype and you report an MRD negative result, then you have to be aware that there may be up to 10% of false negatives. So that's the disadvantage of using a different from normal analysis alone without reference to the diagnostic immunophenotype. Now you probably ask me at this point, well, why can't we use next generation sequencing MRD? It shows promise for tracking multiple mutations, gives information on genetic profiling and the risk for patients, potentially for targeted therapies in the future. We have made progress in establishing NGS MRD assays, and the updated recommendations from the ELN take this into account. It's recognized that there are 2 approaches. There's a panel approach that's used at diagnosis for standard diagnostics, or there's a targeted approach. It's recommended that there has to be sufficient input DNA, which is far higher than is used at diagnosis, and that there has to be sufficient output reads. There has to be error correction to enable the sensitivity of MRD to be at least equivalent to a 0.1% variant allele frequency. And then importantly, after you've error corrected, to clean up the technical background, you have to exclude the biological background, i.e. those non-informative mutations. And those are germline mutations and chip mutations, which at least include GMT3-TEC2 and ASXL1. And there has to be also caution reporting any emerging non-diagnostic mutations. And all this, when an assay is reported, the parameters have to be given. So for NGS MRD, there's been this ongoing question, which mutations are the most prognostic? If you're going to use it, what should you monitor? And there are mutations which are associated with a very high relapse risk, if detected, like FLT3 and RAS and NPM1. There are the mutations which also may be treatment targets, like FLT3 and IDH, NPM1 with venetoclax, and potentially in the future TP53. And then there's mutations that sort of fall in the grey box, including the mutation observed in this patient, the IDH2 mutation, that may be useful for relapse risk, but you have to be able to differentiate what's an oncogenic driver or a pre-leukemic mutation, basically CHIP versus CHOP. And persistent IDH1 and 2 mutations in remission can occur in up to 39% of patients, depending on the variant allele frequency and what type of chemotherapy is used. It may be associated with poor outcomes, but the most recent study showed that if you correct for the presence of other mutations like NPM1, that in fact the monitoring the presence of an IDH mutation did not result in an inferior survival, and therefore IDH should be grouped with DTA. So the presence of an IDH mutation is not prognostic in remission. What about these high-risk mutations, the FLT3-ITD and FLT3-TKD and RAS? Obviously, our patient didn't have them. So the issue with them is that they're often subclonal and have a low negative predictive value. So absence of this doesn't mean that the patient has lost the leukemia. In fact, they might have, be refractory by percentage blasts. So they're best used in combination with additional MRD markers. And the German study, which was on the midostaurin, the ratified data set, it showed that FLT3-ITD persistence was only present in about half of patients when patients are targeted with a FLT3 inhibitor from diagnosis. So our knowledge of this is going to be increasing, but these mutations are unstable, and therefore, although when detected, high relapse risk, if not there, not much use. So going back to this lady, she, as I said, she was requested to have flow cytometric MRD monitoring, and the inset of the results that were produced for this lady. And in fact, she was MRD negative after course 2 and subsequently after course 4. So from our data in the AML-17, we know that from this patient that if she'd been MRD positive after course 2, she'd have a very high relapse risk of 89%. But being MRD negative, she falls in the cohort of patients who have a 50% relapse risk. And that translates into a better survival, a 5-year overall survival of 63%. From the result, we also know that, had she been MRD positive, that there have been 2 studies from the Italian and from the Hovon group that show that MRD-directed treatment improves the survival of the intermediate risk MRD positive patients to that what was previously observed for the intermediate MRD negative patients when these patients are directed to allogeneic stem cell transplant. But for MRD negative patients in both these studies, patients weren't directly directed to transplant and had the same overall favorable prognosis had been observed previously. For this lady, we could say, well, we know she's MRD negative after induction. Can that help us guide benefit from further consolidation courses? Should she have 3 or 4 consolidation courses? And our data from AML-17 showed that although the FLOW-MRD result was prognostic, as previously discussed, it wasn't predictive of benefit from 2 versus 1 consolidation courses. So patients benefited independently of their MRD status, and in fact, benefit was better predicted by genetic subtype. The conversation about oral AZA maintenance, this lady would be potentially suitable for oral AZA maintenance. So again, should her MRD status after course 2 influence the decision for maintenance? And the Quasar study shows that the pre-maintenance flow MRD status is prognostic of median survival, but actually median survival was significantly increased by a few months in both MRD negative and MRD positive patients at baseline. And for the MRD positive patients, that's possibly because some of those get converted to MRD negativity by the ongoing oral AZA maintenance. So with this lady, the MRD status doesn't really help the decisions for consolidation or maintenance. You could consider both. But in fact, she decided with the clinician not to go on to CR1 allo, although she still had a relapse risk of 50%. So she continued to have MRD 3 monthly, and unfortunately, 6 months after the end of treatment, she had MRD relapse, and she converted to MRD negativity. So which the MRD relapse is conversion MRD negativity to MRD positivity, independent of the MRD technology. So how could the MRD then inform allogeneic transplant management? And although an MRD positive result gives you a higher risk of relapse, actually this relapse risk varies from 30 to 60% across different studies. So, you know, we looked at this for patients who would receive reduced intensity treatment, reduced intensity conditioning, and we showed very similar results. The relapse risk of patients MRD positive before transplant was in fact not more than 50%. Although it should be noted that genetics may change this. So for example, FLT3 ITD mutation patients who are positive before transplant have a very high risk of relapse and a very poor survival, as shown on the right here. So the updated ELN recommendations is that pre-transplant MRD positivity should not be viewed as a contraindication to stem cell transplant. But with pre-transplant MRD positivity, you should consider measures to overcome the increased relapse risk, and that may include in younger patients myeloablative conditioning, and that's based on Chris Hourigan's results that were published in JCO in 2020, where they showed that MRD positivity, the prognostic effect was blunted by myeloablative conditioning. Unfortunately, augmented reduced intensity conditioning does not improve post-transplant outcomes in MRD positive patients. When we use amplified reduced intensity conditioning, relapse outcomes were similar to the standard reduced intensity conditioning, and it also had no effect on the adverse prognostic impact of MRD positivity. So what could be considered to reduce relapse risk after transplant? Well, first of all, we also showed that full donor chimerism, that patients who achieved full donor chimerism at month 3 after transplant, even if they'd been MRD positive, had an outcome equivalent to those who are MRD negative before transplant. And that's shown in the red line here. Sorry, the green line here. Another thing that you would consider, as well as different conditioning, is post-transplant maintenance. So for example, in FLT3 mutated patients, that would include sorafenib and may include other FLT3 inhibitors as being tested. We're testing oral AZA after transplant in the Amadeus trial. And the third strategy that we use in the UK is post-transplant MRD monitoring with MRD-directed intervention. And that's best established with qPCR, but we now have data to show that it's also informative by flow cytometric MRD, and we presented that at ASH last year. So to finish up and to summary, how can MRD inform management across the ELN risk groups? And say in the favorable risk group is to identify small populations of patients at high risk of relapse, and that's either after consolidation or by sequential monitoring. In the intermediate risk group is to provide additional data to inform decisions, and that will be a dynamic assessment, particularly if MRD monitoring is continued. In the higher risk group, it's to optimize transplant management, and that will be before and after transplant. And then, and I think this is particularly promising for NGS and MRD technology, once MRD relapse is diagnosed, you can then have MRD level assessment of targeted therapy mutations, so that you can, for example, with FLT3 inhibitors, you can work out whether a patient is FLT3 mutated and then direct the appropriate treatment. So thank you very much for your attention, and I'm very happy to take any questions now.
Thank you so much, Dr. Sylvie Freeman. We have a few questions, and I think we have some time for questions as well. If you could stop sharing, I'll just see if I can. Yeah, thank you so much. I can see the questions now. Okay, so I'll start off with a few questions, and that a lot of it is related to the practical aspects of some of the challenges we have here in India. One is in terms of, we're just trying to understand in the UK, as all of this molecular diagnosis done centrally? And if so, what is the kind of turnaround time, and how do people wait for these results and get back to you, in terms of starting intervention?
Okay, so that's a very good and topical question. So in the UK, genomics has now been organised into centralised laboratories, of which there are 5 across the UK. So to some extent, it has been centralised. We're just in the process of writing some updated laboratory recommendations in AML, and to try and establish the turnaround times, because it is certainly because genetics is directing our treatment choices straight off. We need the rapid turnaround for things like FLT3-ITD mutations, and even sort of rapid FISH and CAR-T. We're getting more and more used to waiting for results for patients, particularly in the older group, before initiating intensive chemotherapy or Ven/Aza. So and reassurance for that was provided by Christoph Brohlig's study in showing that there wasn't any difference in outcome if patients were delayed. Treatment was delayed by 1 or 2 weeks. Obviously, hydroxycarbamide and other agents are doing that. So we are moving towards rapid diagnostics, particularly for the mutations which have approved treatments, or genetic abnormalities with approved treatments.
Okay, so the next question is I'm going to sum up a question from Archit Sunil. He's asking, and I think this is related to some of our challenges, with a conventional karyotype and FLT3 NPM1, how much does NGS add at diagnosis? I'm not talking about MRD here, in determining therapy outside the setting of a clinical trial.
Okay, so from the NGS for NPM1 and FLT3-ITD, I think for NPM1, so in the UK, even patients with FLT3-ITD mutations, NPM1 and FLT3-ITD mutations, we would still base our decisions on MRD monitoring. Okay,
no, Dr. Freeman, sorry, I'm so sorry. This is at diagnosis, not talking about MRD.
Yeah, no, absolutely.
Okay.
But I suppose what I'm saying is that we would still base on that. However, I think now, potentially, if a patient had a DMT, so that triple hit mutation, we would, if the patient was fit enough, we would straight away consider them for upfront allogeneic transplant. For the point of view of the other mutations, and that's important for us for allocating CPX for basically if patients fit into the mild dysplasia related changes AML. So those are the main information that we get from our diagnostic NGS panel.
Okay, and the other question is from Dr. Paresh Jain, is asking, do flow MRD reports at your center routinely have information LOD, LOQ of the assay and details of leukemic signature used to qualify MRD in that case?
Yeah, so with our assays obviously been very, very widely validated. We've established our limit of quantitation at generally for 0.05%. So this is different from how limit of quantitation and detection is used for myeloma and CLL, where it's done by a cell number per leukocytes, and that usually gives much higher sensitivities. So yes, we do have information on that, and we also give information on the aberrant immunophenotypes detected, although we won't necessarily give information on every single aberrant immunophenotype, just the priority ones.
Thank you. Another question that we have is when you do have MRD positivity by multiparameter flow cytometry less than 0.1 pre-transplantation, is there any data on attempting to? I mean, you did show poor outcome, and most people agree that the outcomes are poorer. But is there any data to suggest that trying and attempting to convert them to negativity is a better strategy versus going straight for transplant in the absence of frank disease, hematological disease?
Yeah, there is no data. It's okay. So we had some data in older patients that show that potentially that if a patient, for example, is MRD positive after a first course, if they're sensitive to a second course, those are the ones who do best from transplant. And that probably means that they've got some residual sensitivity to treatment. However, if you've got patients who've had 3 or 4 courses of chemotherapy and there's still MRD positivity, there's no evidence of giving any additional similar treatment is going to help. For low levels of MRD, so it's interesting here because from our data set with reduced intensity, the typical cohort of patients who go for reduced intensity allogeneic transplant, in fact, MRD below 0.2% did not have the same adverse prognostic effect as MRD above 0.2%. So we think that low levels of MRD can, at least in a good majority of patients, be converted and be cleared by the transplant, by the conditioning itself and by the GVL after. So at the moment, we can't recommend any additional treatment, but we do think that this needs testing. And my bias would be that if you are going to use any different treatment, it's got to be, it's got to be something different to what you've already been using.
Thank you. Last question. We recognize there's not much data on this, but just in case you're familiar with or heard of any data that suggests that post-transplant low-level MRD positive, is there any role of working around with tapering immunosuppression, adding maintenance that has shown to make any difference? I mean, we're talking about low-level disease positivity on MRD post-transplant.
Yeah, so low level, as we would qualify for PCR less than 2% or by flow detectable but less than 0.1%. So with a patient, so from we do have data on this with flow and with following patients by PCR, and our flow data shows that patients who have mixed donor T cell chimerism are at the highest risk of relapse. So if we detected low-level disease in patient with mixed donor T cell chimerism, then we would recommend treatment. I think the problem with changing immunosuppression at this stage, or even administering DLI, is that it takes time, and the patient may well relapse before the immune effect has had time to work. So from our point of view, we would say that you should consider some sort of chemotherapy to buy time for the immune effect, for the GBL effect to come into operation.
Okay, with that, we'll stop. And thank you once again for your time, Dr. Freeman. Really appreciate it. And we will put out your email, and hope people may continue to reach out to you for clarifications. With that, we'll move to the last talk, and it's an absolute privilege for me to introduce Dr. John DiPersio, the Virginia E. and Sam J. Goldman Professor in Medicine, Chief of Division of Oncology, Director, Center for Gene and Cellular Immunotherapy at Washington University, St. Louis. He is the past president of the American Society of Blood and Bone Marrow Transplantation, a board member of scientific counselors at the NCI, an elected member of American College, the American Society for Clinical Investigation, past chair of the American Society of Hematology Scientific Committee on Hematopoiesis. He's a physician scientist, and most of us are familiar with Dr. DiPersio's work that has really moved into the clinic, Plerixafor for mobilization and ruxolitinib in GVHD. I've had the privilege of working with Dr. DiPersio, and I know how busy he is, both on the clinical front and on the laboratory side. And we're very grateful to you, Dr. DiPersio, for taking the time off to give us this talk on a very rapidly changing field in terms of immune landscape and immunotherapies in acute myeloid leukemia. Dr. DiPersio.
Thank you, Vikram. So let me see if I can share my screen here. Okay. Well, Vikram, thank you very much for the invitation, first of all. And it's a pleasure, most of all, to see you again. And it's a very tough topic to talk about, because I have to say that when thinking about this, I went round and round with trying to present a lot of negative clinical data, or whether I should just try to tell you what we're thinking about in the setting of having generally failed, really making a huge impact on AML using immunotherapy. So I decided to really focus on some of the forward-thinking laboratory approaches, which I hope will be in the clinic in the near future. So these are my disclosures. My laboratory works on many aspects of transplantation immunology and AML biology, leukemia biology, and I wanted to really just focus a little bit on some of our efforts to use immunotherapy in the treatment of AML and other hematologic diseases, but really focusing on AML. This is just a cartoon showing some of the targets that a number of groups have pursued on the AML cell. Now, the problem with all of these targets, and this is the big problem with AML, is that the targets are expressed also on other cells. And the two major populations of cells that share expression of many of these targets are hematopoietic stem cells, and you can imagine that targeting hematopoietic stem cells will result in some catastrophic events such as pancytopenia, but also the myeloid compartment in general. And when you think about the myeloid compartment, myeloid cells, we're just starting to understand how they contribute to the immune response in humans and in animals. And we really have been exploring the notion of both positive and negative immune effects in the targeting of many different kinds of malignancies. And so myeloid cells, whether they be monocytes or dendritic cells or M1 macrophages or M2 macrophages, however you want to define them, have both positive and negative effects on immune clearance of tumor cells. And so we're going to be dealing with this differential expression of, these are all what's called shared antigens. They're not neoantigens. They're not novel to that particular tumor cell. And that is an important distinction as well. Unlike in a malignant melanoma and some smokers' lung cancers, where the number of mutations is quite high, the chance of generating neoantigens from missense mutations is quite high. In AML, it's quite different. The number of mutations is low, and therefore the chance of actually expressing a unique tumor or patient-specific neoantigen that can be targeted by the immune system of that patient is extremely low. So you have to think about really going after these shared antigens. The advantage of shared antigens are that there's a lot of heterogeneity in AML. And so you can imagine with multiple subclones of AML, some of which may be more sensitive or resistant to traditional therapy, they may all express differentially some of these shared antigens which can be targeted by immunotherapy. So I wanted to talk first about some work we've been doing with bispecific therapy, and bispecifics are, they can be small molecules, intermediate sized molecules, or antibodies which bind to a specific target on malignant cells, specifically AML cells, and then also engage the CD3 TCR receptor, usually at a low affinity, so that binding to the target on AML cells results in a conformational change of these bispecifics, such that they can then induce a signaling event in T cells, which activates the T cells, brings it in close proximity to the target cell, and kills the target cell. Obviously, this has been a big success in ALL and B-cell lymphomas, B-cell leukemias such as blinatumomab, and also there are a number of B-cell bispecifics that look very encouraging for the treatment of multiple myeloma and low-grade follicular lymphomas as well. So in the B cell world, this has really been terrific because we can tolerate B cell penia for a long period of time, but the problem is that targeting AML may be problematic for the reasons I mentioned. So what happens is you basically use these bispecifics to engage a T cell or redirect a T cell to a tumor cell, and that binding to those two antigens results in a conformational change in the binding to the CD3 portion of the T cell receptor, which signals the T cell, and that results in the activation of the T cell and the release of toxic intermediates such as perforin and granzyme, which kills the tumor cell. So these are the studies that have been, and this is just a very abbreviated list of bispecifics that have been out there for a while. They come in three general flavors. Number one, they're targeting a antigen called CD123, which is the low affinity IL-3 receptor. Second is CD33, which is a common differentially expressed myeloid specific antigen, which unfortunately is not expressed on the true primitive leukemia stem cell or on the hematopoietic stem cell. And so it's got advantages in that you're not targeting the very primitive normal hematopoietic stem cell, but it's not targeting that reservoir of leukemia initiating cells either. And then CLL1, which is also very much like CD33 and expressed in the myeloid compartment, but different, but much different from CD33. It's expressed on AML cells, but not expressed on normal hematopoietic stem cells at significant levels, although it's expressed at very low levels in normal hematopoietic stem cells, which is also a problem. So these are the both target antigens that everyone's been going after. So there are small ones such as flotetuzumab, which is a dual affinity retargeting agent, or AMG 330, which is a classic BiTE like blinatumomab, which is made by Amgen. There are medium size bispecifics such as AMV 564, which is a TANDAB. And then there are large bispecifics such as antibody-based bispecifics, which have the advantage of not having to give these drugs by continuous infusion, but have the disadvantage is that once you give them to a patient, the patient's going to get CRS and you really can't take them back, unlike a BiTE, which you can stop the infusion and the patients usually will recover in minutes or an hour or so. We've done most of our work with blinatumomab, with flotetuzumab. Flotetuzumab is a bispecific dual affinity retargeting agent, slightly different in structure from a classic BiTE, but the same size as a BiTE, so it needs to be given by continuous infusion. This is a drug developed by Macrogenics, and it targets CD123. It's been genetically altered so that the binding to the targets are optimized and their codon optimized as well. And the downside is, again, it has to be given by continuous infusion. And it targets the IL-3 receptor. And so this is the expression of CD123, which is the low affinity component of the IL-3 receptor, expressed on many cells. And you can see the expression on a number of cells, including AML, MDS, CML, et cetera. This is just RNA-seq data from our own center looking at the expression of CD123 in a series of AMLs versus normal hematopoietic stem cells. So it's expressed, in summary, it's expressed at low levels, but you can see it's also expressed in normal hematopoietic stem cells at very low levels as well. And specifically, it's expressed in a subset of normal hematopoietic stem cells called plasmacytoid dendritic precursor cells, which are these PDCs that are precursors. They're probably of the lymphoid lineage, but they are involved in antigen presentation. So the trial that's now completed, it was recently published by Jeff Wee in our group in Blood within the last year, looking at dose escalation and then expansion cohort of patients receiving flotetuzumab for relapse refractory AML. And these are patients that had failed multiple lines of therapy, including multiple lines of hypomethylating therapy as well. And this was primarily a safety phase 1 type design with an extension cohort to really gather more safety data. And this is now completed. As I mentioned, it was published in Blood, and we can sort of summarize some of the results by saying that flotetuzumab has acceptable tolerability, but it does induce CRS. And I would say now the most recent update, it's close to 88% of the patients have some level of CRS. Fortunately, only about 10 to 12% of patients have grade 3 CRS, and the incidence of neurotoxicity was very low at around 6%. There are easy ways to treat this, and simply stopping the drug briefly or reducing the dose, and at times giving tocilizumab. In order to tolerate the optimal dose of 500 nanograms per kilogram, one had to increase the dose slowly over time to reduce the incidence of CRS, which is a real problem with every single bispecific agent targeting myeloid cells. So this is the second sort of general consensus conclusion from all of these studies, is that all of the bispecifics to whatever AML target you can imagine, whether it be CD123, CD33, CLL1, there are a few others with other targeting approaches, they have all been associated with very poor response rates and very high CRS rates, even higher than blinatumomab. This is the CR rates and partial response rates from the first group of patients. And again, I would refer you to the paper that was just published in Blood for the updated. But this is very similar to what the updated data shows, and that is that the patients that responded the best were patients that had primary refractory AML, interestingly, not the patients that had been in remission for a long period of time and then relapsed, which are the classic patients for responding best to standard chemotherapy or salvage chemotherapy. The second is that the patients that responded the best were those that had an infiltrate in their bone marrow before treatment that was active or inflammatory in nature. They expressed genes that were high in gamma interferon signaling genes. And we published this recently in Science and Translational Medicine with Sergio Rotola from Nottingham in England. So this is also what I was just mentioning. The early progressors had expression of inflammatory markers in their bone marrow, while the patients that didn't respond had lower markers for inflammation. And so what is obvious, if the patients that respond have an increased incidence of PD-L1 expression, which is gamma interferon mediated, then, and if resistance occurs in most of these patients, which we did show in this study, even though 20 to 25% could achieve a remission, in our view, that is not optimal and can be improved. And so in the laboratory, we added checkpoint inhibitors, and we found surprisingly only minimal benefit. And then this minimal benefit was also, instead of just adding checkpoint inhibitors as an antibody, the group from Munich also developed a bispecific for CD33, which actually could block PD-1 and PD-L1 as well. These are called checkpoint inhibitory T-cell engaging antibodies, and these were developed in conjunction with Amgen, but I don't think they've seen the light of day. But this is an interesting approach where you're actually using the observation that when you use a bispecific, you also turn on the counter-regulatory responses that would block immune activation, such as PD-1, PD-L1. And this compound is a bispecific, but also blocks that pathway. And so this and using checkpoint inhibitor therapy are one of the future directions for the development of flotetuzumab. And so this is the way the study was designed, and this is again completed now. There was a dose response phase 1 portion, and then a large expansion cohort. And then a number of patients were also given ruxolitinib prophylaxis, which we reported at ASH this past year, to reduce the incidence of CRS. And there was a clinical reduction in CRS, and this is based on some laboratory data that we had generated, but there was not a significant improvement in the number of doses that had to be discontinued or dose reductions for these patients. So even though ruxolitinib appeared to have some effect, it was not clearly eliminating CRS in these patients. And then, of course, as a way of improving outcomes, they have planned to give a checkpoint inhibitor with flotetuzumab, and that study is ongoing. Well, so the bottom line from all of the, and I don't have time to go through all the studies for bispecifics, except to say that they all show the same thing: lots of CRS and very poor response rates. And so why is that? I'm going to get back to that in 1 second. Second area I want to talk about is the most powerful immune effect on AML, and that's through an allogeneic transplant. But as you all know, that even though patients may relapse after allogeneic transplant, may respond after allogeneic transplant, many also relapse. And so the question is, what is the mechanism of immune escape after an allogeneic transplant? And these are just some of the pathways that have been implicated that were recently reviewed by Rob Zeisser and Luca Vago in Blood a few years ago. So we were interested in the genetics of relapse. And so, 50 to 90% of AML enter complete remission, but then will relapse later on. And then, the most effective consolidation to prevent relapse is allo transplant because of this important graft versus leukemia effect. And we think that the graft versus leukemia effect is mediated by two things: the inflammatory environment that conditioning in GVHD causes can enhance T cell responses, but also the T cells are directed to probably minor histocompatibility antigens that we've had trouble identifying that differ from host and donor. So little is known about the mechanism of relapse, and extramedullary AML occurs infrequently at diagnosis, but much more frequently at the time of relapse, which suggests that might be a way of escaping the immune system of the donor T cells. And then there were recent studies by, again, the Milan group showing that in the context of a haploidentical transplant, there's loss of the complete mismatched HLA allele in haplotransplants, suggesting that might be a mechanism of relapse. So we were interested in the genomics, and we really started looking at this a long time ago, 10 years ago. In fact, this was a sort of an important paper in Nature looking at the genomic bottlenecks in relapse, both after standard chemotherapy and transplant in patients with AML. And the interesting thing here is that some of the clones that eventually resulted in death of the patient were barely detectable in the original population. And many of the clones that were abundant in the original population were extinguished by therapy and could not be found in the final population that was killing the patient. So the question is, does this clonal evolution occur after allotransplant in patients that relapse? And so Allegra Petty in our group looked at allotransplant patients that had relapsed, and in all cases, as expected, just like after chemotherapy, new mutations were observed at the time of relapse. But the clonal dynamics of relapse after allotransplant looked very similar to what we see after chemotherapy. There were no recurrent mutations that were associated with relapse. In other words, there were no specific genes that were always mutated that were always associated with relapse. They were mutations all over the genome, and that these mutations were not specifically common between patients. And there were no mutations in immune modulations and cell trafficking, cell adhesion, unlike the VAGO study. But remember, what this study is looking at is matched sibling and matched unrelated donor transplants. And more importantly, with our data set, unlike the haploidentical data set, there was no loss of heterozygosity in the HLA gene complex. So Matt Christopher and Mike Rettig, then fellows, now faculty members, made some important observations after Allegra showed that one of the interesting things in about 50%, 40 to 50% of the patients that relapsed after allotransplant was a decrease in expression of class 2 genes at the RNA level. And so we thought this might be just an artifact, selection bias, and that Mike and Matt went and actually did flow cytometry on these patients. You can see that there was this patient, the sort of brown is relapse, the blue is diagnosis, and the gray is negative control for HLA class 2. And these antibodies bind to all class 2. And you can see that in this upper patient that this patient had at diagnosis all very high expression of class 2. But at relapse after transplant, there was complete, this is actually relapse after chemotherapy in the left. And then at the time of relapse, that same patient, when that patient relapsed after transplant, there was complete loss of class 2, which really supported the observation of the single cell RNA-seq data that was identified by Allegra Petty. And you can see that down below, there are patients that have complete downregulation after these first two patients of class 2, and then partial downregulation. And some patients had no downregulation. And about 40% of patients had this unique downregulation of all class, not 1 or 2, but all class 2 antigens. And what they went ahead and showed is that that there was no such alteration in class 1 expression, and that when these cells were then exposed to gamma interferon, those cells that had lost class 2 expression, they could re-express class 2 nicely. And so there was a way that one could actually re-express class 2, and therefore potentially making an invisible AML cell that had cloaked itself after allotransplant to now being visible again. The problem is, how do you get interferon to all of these AML cells? Well, we knew that class 2 expression was dependent on a specific gene called C2TA, which is the master regulator of all class 2 genes. And so when we look closely, we found that this gene, C2TA, in patients that relapsed after allotransplant and had lost expression of class 2 and were cloaked and could not be recognized by the donor T cells, those AML blasts had complete silencing or loss of expression at the epigenetic level, not a mutation, but just decreased expression of C2TA, which explains nicely what we and the group from Milan eventually confirmed our data in a nice Nature Medicine paper. And this is what Matt did. He took these AML cells and said, okay, well, let's inject them into an immunodeficient mouse. And when he did, he found in the left panel, there's very little expression of class 2. So once they lose it, it's lost. But what Matt did is then he put in donor lymphocytes and showed that those donor lymphocytes, when they recognize the AML, degranulate and get activated and release gamma interferon. And this release of gamma interferon induces class 2 expression. And this is just showing the same cells exposed to gamma interferon, which has been injected right into the mouse. And you can see that these mice tolerated this very, very poorly, but did upregulate class 2 expression. So can we do this in a more safe and efficient way? And so we decided to go back to the bispecific drug flotetuzumab and say, could we use a bispecific to bring a T cell close to an AML cell that had lost class 2 expression after transplant and get it to be activated and then dump gamma interferon right next to the cell so that we could induce increased gamma interferon expression near the target, which would upregulate class 2. And so this is just a picture showing that this is what you see when you give flotetuzumab. And it's, let me see if I can, in this insert, you can see the white cell is a T cell and the red cell is an AML blast. And the T cell actually binds directly to it in the context of getting flotetuzumab. And we can show and we showed in this paper that gamma interferon was secreted by these engaged T cells, which is exactly what we wanted to do. And so we thought, could we give this bispecific to patients when they relapse after transplant, and thereby safely administering gamma interferon just locally to the tumor cells, which would upregulate class 2 and now make them not only susceptible to targeting with the bispecific, but all the innocent bystander T cells would now see them because the class 2 expression would be upregulated. So this is just an example of what happens in a THP1 cell, which is a cell line. When we give gamma interferon, you can see there's a huge increase in class 2 expression. And this is like a model for testing this mechanism. And when we did this same study with these same cells using the bispecific therapy, you can see that in the left panel, that when you give the bispecific, as expected with human T cells, the AML cell is killed. That's the blue bars. In the absence of the DART bispecific, there's no killing as you would expect. And the killing is associated with an enormous amount of gamma interferon production and upregulation of class 2 expression in those cells. So this is prima facie evidence to support this approach in patients. And so this is what the trial looks like now. And we're just starting this trial. We've had the first 4 or 5 patients in this study, and we're actually giving flotetuzumab to patients who relapse after transplant that have lost their class 2 expression. That's about half the patients. And then if they don't respond, then we give them a donor lymphocyte infusion, because there is a possibility that the number of T cells or the T cells that are present in these patients initially after transplant are exhausted. And so we're giving a donor lymphocyte infusion in cycle 2 with flotetuzumab to see, number one, if we can turn on class 2 where it was turned off, and number 2, do we have any better clinical responses? Okay, so that is the bispecific story, and the CAR-T cell story is just as depressing. There have been a number of studies looking at CAR-Ts targeting the antigens I just mentioned earlier, 123, 33, and CLL1. And the only study that looks halfway encouraging is this very small study from China. And so you have to take it with a grain of salt. It may or may not be true. And that what happens is, in all of these studies, just like in the BITE studies, a lot of CRS and not much clinical responses. So why is this? So we wanted to see if we could generate CAR-T cells and get them to work better. So this is just, I just took a little poetic license and modified the famous Salvador Dali painting to show you that our goal here is really to enhance not CAT's memory, but CAR-T cells memory using various approaches. And I won't go into this in depth, but there are a lot of approaches that have been used to enhance the effect of CAR-Ts, to enhance their expansion, their persistence, and their anti-tumor activity. And so we didn't pursue any of these directions, but actually tried to focus on a novel approach using a genetically modified long-acting interleukin-7 molecule. And we had a lot of preliminary data to support the role of IL-7 in the expansion and persistence of CAR-Ts. And this is just work by Matt Cooper showing that when we tested this long-acting IL-7, which has a half-life of 2 weeks versus just minutes of the recombinant IL-7, we could actually show that our CAR-Ts, when we generated in the lab, could be expanded nicely compared to those CAR-Ts that were not exposed to this long-acting IL-7. So that looked good. And then we actually treated some patients with glioblastoma. This is Jean Campion's work And when she gave this in increasing doses to patients with glioblastoma, there was an increased number of T cells in the peripheral blood. These are the blue lines on the right upper panel here. And so we had evidence in the lab that it was expanding CAR-Ts in vitro, that it was actually inducing the expansion of normal CAR-Ts in glioblastoma patients. And so we did the following experiment. We used a cell line that had a luciferase in it so we could track them in mice, and we injected them with CAR-T cells that were either targeting the CD2 antigen or an irrelevant target, CD19. And then we either gave the mice NTI-7, which is this long-acting IL-7, or we did not. And we wanted to know, number one, did the CAR-T cells kill the tumor appropriately? And number two, did the addition of NTI-7 actually enhance that effect? And so this was all based on preliminary work by Matt Cooper, and I won't go into this, but the way we do these experiments is that we use a number of gene editing approaches to study these T cells in mice so that they don't cause xenogenic graft versus host disease. And this is the result of that experiment. The red line shows what happens when you just inject tumor cells into these mice. They rapidly expand and kill the mice. And when you give this NTI-7, these tumor cells expand at the same rate and the mice die very quickly. When you target these tumor cells, which have CD2 on the surface with an irrelevant CAR-T, that's a CAR-T to CD19, a B-cell antigen, then there's no effect, as you would expect. However, when you use a CAR-T to CD2, which is the target on these leukemia cells, you can see that that CAR-T works very well. This is the blue line here. And then if you look at the open circle blue lines, when you give this IL-7 molecule, all the mice essentially are cured. And you can see this panel on the left where all the mice have no evidence of disease. So he said, oh, is that possible? And so we did the same thing with a B-cell tumor. That was previously with a T-cell tumor. This is with a B-cell tumor. So we do the same experiment. And look what we see. We see at 3 weeks in animals that did not receive this IL-7, there's a modest expansion of these CAR-Ts, which is in this compartment here. But in the animals at 3 weeks that got this IL-7, and they only got 2 doses, you can see there's a monumental expansion of CAR-Ts. And by 4 weeks, in the mice that have had a modest response, a little bit of a response to therapy and a little bit of a prolongation of survival, those CAR-Ts have regressed, as we see in patients. But in these mice that received the NTI-7, there's a continued and massive expansion of CAR-Ts. So the CAR-Ts in the mice that don't get IL-7 go up about 2 logs, and the CAR-Ts that are expanded with the NTI-7 go up 6 logs. So almost 1 million fold. And obviously that results in complete curing of all these mice. And the question you might ask, since we're talking about AML, does this work in AML? We did the same experiment with AML, and we targeted in this experiment CD33. And so that's the upper panel. You can see that the CD33 CAR resulted in a little delay of progression of the tumors, but the mice all died quickly. It worked, but the mice progressed. We gave the same number of CAR-Ts to CD33, but just gave them 3 doses of this NTI-7, and you can see that all the mice were cured and 100% of the mice survived. And there's a huge increase in the number of CAR-Ts in the periphery, and there's no evidence of disease. So there are ways that we can overcome some of these CAR-T cell issues. And the question is, will this have an effect on the treatment of AML in the future? This drug is now being tested in the clinic, and we're treating our 4th patient this week. And so we're determining if the addition of an IL-7 analog will enhance the expansion, persistence, and anti-tumor efficacy of CAR-T cells. Initially, this study is in B-cell large cell lymphoma patients, but eventually when we move into the AML field, we will hopefully add this to our AML studies as well. So what about targeting AML? And so I told you that so far the CAR-T cell trials and the bispecific trials are very disappointing. So what Miriam Kim did, Miriam is a talented junior faculty member in the lab. what she did is she said, okay, well, why is this? Why, when we target B cell ALL, we get a nice response and we get tolerable side effects. But when we target AML, we get really big problems and very little effect. So she hypothesized that when you infuse CAR-T cells to a B cell malignancy, you don't have really a redirecting of these CAR-Ts to any other cell except for normal B cells and the B cell malignancy. And that results in a communication between malignant B cells and normal myeloid cells, which results in the production of IL-6 and cytokine release syndrome. But this is tolerable and we can treat it, and we see it in all of our CAR-T cell patients now. However, when we target myeloid cells, a different thing is happening. Number one is that CAR-Ts are not only targeting the malignant myeloid cells, but also this huge number of myeloid cells that are normal in the hematopoietic system, which are in the tissues like Kupffer cells and pneumocytes and all of the monocytes that are in all the tissues. And so there's a huge reservoir of these antigen positive normal myeloid cells, and these are the cells that make all of the IL-6. And we and other groups have shown this, and it's not the B cells that get killed that release IL-6 or the T cells that make IL-6. It's this communication between an activated T cell and a normal bystander monocyte, which makes all of the cytokines which cause our CRS. But when you directly target myeloid cells, you have marked increase in CRS, as you might expect, because you're directly targeting these cells that make all those cytokines. And you have this huge sink. So you have to get past these cells to get to the malignant cells. And therefore, there's impaired T cell activity and anti-tumor effects. So what she did is she made a B cell, and she put a myeloid antigen CD33 and a lymphoid antigen CD19 in these. And you could see that when she made CARs to the myeloid antigen or to the lymphoid antigen in vitro, these cells were killed nicely. She did the same thing with a myeloid cell. This is THP1. These are the myeloid cells I showed you earlier. So the top one at Ramos is a B cell, the bottom one is a myeloid cell. And she did the same thing. She put CD33 on these and she put CD19 on these and had CARs to each of these antigens. Again, showed that in vitro, they kill the targets nicely, just as you would expect compared to the black line, which is untransduced or just regular T cells without the CAR. And what she didn't expect to find is when she looked at the role, because we think of monocytes as tumor as suppressive cells. What she found is that when she added monocytes either from the peripheral blood or from bone marrow, she found not only did she found the opposite of what she thought she'd found, and that is that here the black lines are the tumor cells expanding in vitro, but when she added the peripheral blood or bone marrow monocytes, the actual control of tumor growth was improved. So the conclusion was just the opposite of what many people think, is that these monocytes that are present are absolutely, they have a positive role potentially in tumor clearance and not a suppressive role. And so she showed that when she targeted a lymphoid tumor, she got a little bit of IL-6 production because there's some monocytes in the mix. But when she directly targeted the myeloid tumors, there was a huge amount of IL-6 produced, which is what we see in our patients that get bispecifics or CAR-Ts to AML. So this is the notion of too much target in irrelevant cells, and also too much direct targeting of cells that make all the cytokines, more CRS and less efficacy. And so she said, okay, well, let's try to develop a mouse model of human AML. And so what she did, instead of using a completely immunodeficient mouse, she took mice that were immunodeficient that had some transgenes in them that expressed human cytokines, so human stem cells could grow in them. And she injected human cord blood CD34 cells and engrafted these mice. So these mice at 4 weeks had human hematopoiesis in them. So they're immunodeficient mice now with human hematopoiesis and human myeloid cells in them. And then she basically injected untransduced T cells from the same cord blood, CAR T cell 33 from the same cord blood, or CAR-19. So there's no allogeneic difference between the T cells out of the cord blood and made CARs out of them, and then did weekly bleedings. And so here's what happened to the B cells in these animals. So the B cells were completely eliminated by CARs to 19, as you would expect. And it had no effect on the myeloid cell. And when you target CD33, which is the myeloid antigen, you have no effect on the B cells, as you would expect. And when you do the same and you look at the myeloid cells, you can see that the CAR to CD33 eliminates all the human myeloid cells, but has very little effect on human B cells. And what it was fascinating to see was that when she directly targeted the human myeloid cells, now remember, there's no tumor in here, just the human myeloid cells, there was a huge amount of human IL-6 that was produced, and these mice started to lose weight. So she did the next experiment, same experiment, except that she injected TFP1 tumor cells that express CD19. So they express both CD33 and CD19. So these mice were the same immunodeficient mice that had been engrafted with human bone marrow, and then, but the only difference is they also had tumor. And then she did the same experiment with untransduced CAR to the myeloid antigen CD33, or CARs to the lymphoid antigen CD19, which are present on these THP1 cells, which are myeloid. And so you can see with the tumor alone, there's progression in all of these groups. However, when she added hematopoietic stem cells, so there's no HSCs in this experiment. So these tumors actually pretty marched along pretty well. But when she added the HSCs, you can see, just like in the in vitro experiments, and just the opposite of what you would think, there was an excellent control of these tumors, dramatic and excellent control of these tumors in vivo. Again, suggesting that the myeloid cells do provide some clear-cut positive impact on anti-tumor effects. And so you want to harness that positive effect, but you want to block somehow this huge sink of antigen that you're targeting, which are on normal myeloid cells, and also reduce the CRS. So this is what she found when she looked at these mice. She found that when she targeted AML, the CD33 target, you can see that these mice lose weight, and they express quite a bit of IL-6. So again, this is exactly what we were saying, in that this direct targeting of myeloid cells results in the big production of IL-6 and CRS, and also this affects the weight and health of the mice. Now, the most important thing is this experiment, where she did the same thing, except she asked the question, what if I take the target out of the stem cells of the cord blood that we're putting into these mice? So she took wild type cord blood stem cells and grafted these mice. These cord blood stem cells expressed CD33. And then she took another batch from the same cord and knocked out the CD33 antigen using CRISPR, and engrafted these mice with the same hematopoietic stem cells, but they lacked the gene CD33. So all the myeloid cells did not express this gene anymore. So now she wanted to know, does this make a difference? And then she put in her THP1 cells, which again express CD33, and injected a CD33 CAR and looked and see what happened. So first of all, if the two groups, the control engrafted and the CD33 knockout engrafted, there was initial control of the disease, but in the wild type, then the tumor started to progress again. Number two is that there was very little expansion of those CAR-Ts in the control group. And while when she actually looked at the expansion of CAR-Ts in the knockout group, there was beautiful expansion. And most amazingly, when she looked at the weight change and the IL-6 production, the control group, there was a huge decrease in weight and a huge increase in IL-6, which was completely eliminated by knocking out CD33 in the stem cell population, which makes a lot of sense. And so this is the model. The model is that, like in CAR and in B-cell malignancies, the model is that if you just directly target the tumor and you use innocent bystander macrophages in there, you're going to have very efficient targeting. But if you have a myeloid malignancy with that target on the myeloid cells, and there's going to be a huge sink that you have to get around, a lot of CRS and dysfunctional T cells. And when you knock out this CAR-T in the stem cells, you get very effective anti-tumor effects, and you get no CRS. And so this is the way I think that we could potentially go forward. The question is how to do this in a human being. So she also showed that this could be done in a different disease. I'm not going to have time to go through this. This was just published in JCI. So this is the same concept in T-cell ALL, in which she knocked out the target in the stem cells and found that when she went and then targeted these malignancies in mice that had knocked out the target gene, that the efficacy, the anti-tumor efficacy was dramatically enhanced, and the CRS was eliminated completely. So I won't go through all this stuff. So the bottom line from all this is that poor progress so far with BiTEs and CARs. Why? Because of this huge sink, and direct targeting of AML cells results in the production of CRS. But one way around this is to find an antigen that's not expressed on myeloid cells, which people have not been able to do so far, or try to delete this antigen. And so this is just an example of two antigens that we've picked up by proteomics that are not expressed on AML cells. And so this is another approach. And the final approach would be to see if we could target two antigens at the same time. So in conclusion, targeting AML using immunotherapy has been challenging. It's limited by the expression of differentially expressed targets. Expression of known targets is problematic on HSCs because of pancytopenia, and then expression of known targets on myeloid cells is problematic because of limited efficacy and CRS. The on-target sink in myeloid cells results in excessive CRS and limited efficacy, and deletion of the target in myeloid compartment is one approach, but it's complicated and risky, and novel targets or combinatorial targeting may be a way out of this. And that immunotherapeutic targeting may overcome some of the genetic heterogeneity and resistance of AML to traditional therapies. And I want to thank the people that did the work: Mike Rettig, Matt Cooper, Julie Ritchie, Miriam Kim, Armin Gabati, Zach Krees, and our collaborators and funding sources. Thank you.
Thank you so much, Dr. DiPersio. Really an extensive talk and a lot of work, and really cutting edge. We can see the challenges ahead, and hope we do make progress because it's really needed in acute myeloid leukemia. A few questions. One is from Dr. Paresh Jain. He wanted to know, in the flotizumab trial, was patient selection based on a certain quantum of CD123 expression, or was there any pre-selection based on CD123 expression?
The answer is no. There was no selection based on 123, and it's a good question because 123 expression does vary from patient to patient, and but there was no relationship between 123 expression and responses. The only relationship was in the patients that had primary refractory disease did better, just the opposite of chemotherapy patients. And the second is that when one looked at the bone marrow, those patients that had an inflammatory bone marrow with lots of T cells and gamma interferon signaling did a lot better than patients that did not.
Thanks. Second question that just a clarification is with the IL-7 analog, which seems to help in CAR T-cell proliferation. I'm just curious, will there be an optimal timing at which to administer this, say in the setting of a CAR, CD19 directed CAR? Would early increase the risk of CRS and neurotoxicity? Would you want to bring it on when you think some senescence and fatigue is setting in the T cells? Or how would you propose that it be used in the future?
Yeah, that's a super good question. And so we have a trial, as I showed you, that we're doing right now. The FDA asked us exactly the same question. And so we had mouse experiments to support the notion that giving it early resulted in the biggest expansion. I showed you some of that, 1,000,000-fold.
Yes.
But when we use that early intervention in an immunocompetent model where there's monocytes, the animals suffered from more CRS. And so you can see that you have to be careful. If you go too early, you may end up expanding the T cells more but causing more CRS. So the FDA made us, we had originally recommended the first dose be given at day 7, and they said, no, for this initial study, you have to start at day 21. So we're actually starting this trial at the FDA's mandate based on exactly that question, that they were concerned that too early an intervention would cause too much expansion and too much CRS, and so they made us start late. And if those patients tolerate that, then we can move sooner after infusion.
Thank you so much. Just one last question, and more out of my own interest. If you were to go with the concept of using stem cells which have knocked out CD33, would that be an option in the clinic to consider a gene therapy kind of product along with the CAR-T?
Yes, and you think it's complicated to do. It's pretty easy to do, actually. We do all of this knockouts in one day in the laboratory. And so there are 2 companies in the United States that are currently pursuing this. One is using gemtuzumab, so they delete CD33 and then give CD33 ADC after transplant. And there's a second company at Penn that's starting to gear up for clinical trials. And so we're interested in doing this because we're convinced that there may not be any real good antigens that are selectively expressed in AML and not monocytes. And so we think that, you have to pick your antigens carefully, and antigens that when knocked out in mice don't cause any problems. So CD33 and CLL1, we think patients and mice can live without those 2 antigens and live normally. And so we're thinking of those 2 antigens because they can be eliminated without any long-term side effects. And then you have no antigen in the sink, and you have no antigen on the myeloid cells. The myeloid cells can provide the positive effects, but they're not going to have the target so that they produce tons of cytokines. So I think it can be done. It's complicated and it's risky because it's gene editing. And there's a lot of, but AML is a terrible disease. It's just the worst. And we've made hardly any progress in immunotherapy, and it's pitiful. And so you have to think outside the box.
Thank you so much, Dr. DiPersio. I think with that, we are already running a little over time. So we will have to close the session. And thank you so much, Dr. DiPersio, once again for your time. And look forward to having you more often with these sessions. Thank you all the participants. I'd like to thank ICH, Dr. Tejinder Singh, our Dean, and all the participants on this webinar. And I'd also thank the Riverroot and Nimesh Jain for organizing and facilitating and putting this whole show together. Thank you, everyone. Good night and see you soon.